Our next and final speaker is Emily Fabiaschi, Senior Associate at Third Sector Capital Partners. As Damien mentioned earlier, Third Sector Capital is leading many projects to assess the feasibility of using Pay for Success across the country, and several of these focus on early childhood, and Emily will be sharing some of their work with us today.
Great. Thank you so much, Catherine, and thank you, NIHCM, for having me on this panel with so many esteemed presenters. And I think a lot of what we've talked about already will tie into my presentation as well. So Third Sector Capital Partners is a nonprofit advisory organization, and our mission is to accelerate America's transition to a performance-based social sector. And so the way we do that is through technical assistance work, and a lot of it is focused on Pay for Success. And for us, Pay for Success is really about getting better outcomes for vulnerable populations and making sure that the social services that we're funding in this country are really doing the best job that they can at helping those folks. And so we really think about it from two perspectives. One is that we can do a lot of this work by changing the way we procure and contract for these services. And then the second piece, which we really think about as more of a means to that end, is thinking about how we do private-public partnerships and how we use private funding to help advance those contracting goals. And so a lot of that has to do with data, which we already talked about a bit, and I'll go into that because those contracts really do force you to look at the way data is currently siloed in different systems. And so today I'm going to be speaking a bit about when does PFS make sense, what is the development process. As Mr. Galloway talked about, it takes a while, so I want to go through kind of what those steps are and the timeline, as well as talking about a bit of Third Sector's work in the childhood health space, both in feasibility assessments, many of which are funded through the Social Innovation Fund, as Mr. Thorman talked about, as well as some project constructions, so actually getting the Pay for Success contracts together. And so the first piece is there's a bunch of different areas that you really need to assess to understand if Pay for Success might be right for you or in what format it might be right for you. Do you need that outside financing? What providers might be the right ones for your particular need in terms of an outcome that you're trying to target? And so the first piece we think about is the significant unmet need or targetable population. So who exactly do you want to serve in this project and why? Is there a particular population in your community that you see having a need? Is there a stat that you're really worried about, like that 45th percentile or 45th state in the country for child well-being? And then thinking through, how do you actually target that population? How can you get services to them? How can you reach them and retain them in programs? Also identifying what sort of services are out there for this population right now. The second piece we usually look at is around data. So if you have some particular outcomes that you want to prioritize, maybe some of those health outcomes like ER visits or birth spacing, who is capturing data on those outcomes? And who is capturing data on participants in different service programs? And how can we start to link that data so that we can really understand for folks that are served, what are their outcomes, both short-term and long-term. And a lot of times this involves some intense work around data sharing agreements, institutional review boards, human service agreements, and really understanding what are your research questions, what are you trying to find out here, and that involves a lot of different project partners. The next piece is thinking through interventions that work. So do you already have an intervention in your jurisdiction, such as nurse-family partnership, that you know has a track record of really great outcomes and you want to expand it? Or are you thinking through some issues where you haven't actually seen interventions in your jurisdiction and you want to look to national models and see if maybe they would come to your jurisdiction or adopt a program that's being used in the next county but not necessarily in your county just yet? And then thinking through, are the people providing this intervention able to do so with fidelity to that model? So in the nurse-family partnership example, are the organizations on the ground implementing that evidence-based curriculum doing a good job at it, and are they able to scale up if you were to, say, take them from 200 slots of home visiting to 400 slots? What would that mean in terms of them hiring staff, training that staff, managing to a contract that is based on outcomes instead of outputs or cost reimbursement? The next piece we think about is that financial benefit and social benefit. So a lot has been spoken about that in terms of a return on investment, including lots of different aspects, particularly for early childhood, around not just the child, but their parents, and not just financial savings that you can calculate in the short term, but also thinking through more long-term savings as well. The next thing we typically think about is risk mitigation or the appropriate evaluation. And so this is really starting to think through, what does success mean, and does that mean that we need to have some sort of a comparison group that did not receive the intervention to really know that it worked? How do we make sure that we're not denying service to folks that really need it, and that all of the right risk guards are in place so that when we evaluate this program, we really can say definitively that it was successful and that the evaluation design was ethical. The next piece would be the funder interest. So if a project is going to require some of that outside funding, who are the right folks to get involved there? Is it the philanthropic community? Is it private investors like banks and other parties? Is it a mix of both of those? And really understanding what their appetite is for the type of project you're looking at. Certain funders certainly have geographic focus that they like to look at. Certain ones have interventions or issue areas that they're particularly passionate about. So starting to understand in your particular jurisdiction, and then also if there's national funders, what are they really interested in looking at? And finally, government leadership is something that we think is most important, and so I've left it for last. And that is, the whole basis for these projects is really about paying for successful outcomes. And if you don't have a government champion that's willing to pay for those successful outcomes, to lobby for the money, to put in the work around changing the way contracts are done with service providers, then a project really isn't ever going to take off. So having that government leadership is something that is really crucial. And so just in terms of thinking about what it takes to get to a launch project, so to relate back to some of the previous speakers, there are only 11 Pay-for-Success projects launched in the U.S., the South Carolina Nurse-Family Partnership being one of the most recent ones to launch. That being said, there are dozens of feasibility assessments that have been done. And so as you can imagine, as you sort of move along this chart from left to right, jurisdictions may think about pay-for-success, sort of do a landscape analysis around what issue area might make sense for them, and then they may move into doing a feasibility assessment, or they may not. You sort of get some fallout all along the way here until you get all the way to launching a project. And we really think that all of these steps along the way are really important, whether you progress on to the next step to the right or not. What we found is that every jurisdiction we work with, whether it be in landscape phase, a feasibility assessment, doing some of the capacity building, or actually starting to construct these contracts, have found that bringing together the stakeholders you need, asking these questions around outcomes and where data lives, have been really successful for them in terms of shifting their mindset, either at a government agency or at a service provider, around getting to those better outcomes and thinking critically about the best way to deliver services. And so we think that every piece of this map here are very important. And what you're going to find is that some feasibility studies, you may get through the end of it and find, the data systems just aren't in a place right now where you can track outcomes. So you need to do some of that capacity building to start linking those data systems. Or you just don't have a government end payer, so you don't have a pot of money that you can use for those success payments. And so work needs to be done there. Or you may find that all the pieces are in place and there are some clear next steps to actually start constructing one of these projects. And so to give a bit more detail about the difference between feasibility assessment and project construction, we've put together this slide. And I would say the main difference is that the feasibility assessment is really more of a due diligence process where you're trying to understand the readiness of the jurisdiction and the particular issue area around all of those pieces I talked about a few slides before, the target population, the data. A huge piece of this is just bringing together all the stakeholders who might be involved. So talking to those providers, talking to people at the different government agencies that would be involved, talking to the business community, getting everyone together to talk about those outcomes and to talk about a plan for thinking about actually putting one of these contracts in place and identifying those areas where you might need to do some of that capacity building that takes a few years. And then if the decision is made to actually construct a project, project construction usually kicks off with a request for proposals with an RFP for service providers. And that RFP usually goes through what outcomes the jurisdiction is trying to get and asks the providers to respond with what levels of outcomes they think they could achieve. And then the actual nitty-gritty work goes underway of actually putting together that contract. And so these contracts are pretty specific in terms of the exact outcomes that will be measured, the evaluation plan for measuring those outcomes, the price that will be paid for each successful outcome, the timing, any sort of governance committee that might need to be put together in case there are issues with referrals or the size of the project. And so all of that is really starting to put pen to paper and draft term sheets and contracts. And so I wanted to take a little bit of time to speak about some of third sector's projects that are specifically focused around childhood and health. And so third sector is a proud grantee of the Social Innovation Fund. And so we were awarded $2 million to do technical assistance around Pay for Success in the form of these feasibility assessments. And so the way that that's taken place is we had one cohort that we're just starting to finish up of subrecipients that we worked with, and that was all in the Healthy Future space of the Social Innovation Fund. And so this slide goes through our 9 subrecipients there. And as we started to wrap up these feasibility assessments, what you'll see is that they've ended up in some very different places in terms of how they'll move forward. But I think if you spoke to any of them, they would say that the process of just going through this type of assessment has been really useful, not only for the specific intervention that they looked at, be it home visiting or pre-K, but also just in the sort of organizational mindset around utilizing data to get better outcomes and working that into contracts. And so one project that we worked on was with the State of Washington's Department of Early Learning. And so that is a very exciting cabinet-level governor agency that does all of the programming for 0 to 5-year-olds, and they wanted to look at expanding their home visiting portfolio, which includes nurse-family partnership as well as parents as teachers and a few other national offices throughout the state. And so what we found in that state was that there was a big disconnect in terms of the data systems. The state was not receiving any data on the individual level in terms of people participating in the home visiting program. And so within the time frame of our feasibility study, it wasn't going to be, it wasn't feasible for us to link data between those folks who were served and their health and educational outcomes. We were able to look at it on a county-by-county basis, but not on an individual level basis, actually doing that linking. And so a huge finding from that was that one of our recommendations was some sort of early childhood data mart, where all of this early childhood data that is currently siloed by different agencies be brought together and linked in such a way that still respects all of the privacy considerations for that data, be it HIPAA, FERPA, but is able to give a more longitudinal picture of how the children and the mothers who go through these home visiting programs, how they fare on a lot of these educational and health outcomes. So they are right now digesting the feasibility study. We had a great final meeting with them where we had folks from philanthropy, folks from different government agencies, from the legislature, all together talking about how they might be able to make that really exciting data mart happen and how they might be able to change some contracts through that. Another place where we worked was with Orange County's First Five Commission. And so every county in California has a First Five Commission, and all of their revenue comes from tobacco taxes. And one of the things, as people stop smoking as much, means there's less revenue going to these commissions. So they are trying to grapple with how to continue their programming, and we were very excited to look at their Bridges network, which is a really exciting way to think about screening and referring mothers into home visiting services, because different home visiting models have different dosages, have different focuses that are right for different types of mothers. And so a big part of Pay for Success is trying to find the right level of service for the mom or the youth who needs that. And so the Bridges Network is one where they're screening people right at the hospital. So you're getting nearly all the mothers in Orange County getting some sort of screening, and then, if needed, referred into home visiting. And so we really like that idea of using some sort of screening process to match people with services. And we looked at potentially having a managed care organization be the end payer for success payments. In the short term, we're not moving towards a project construction around that, but the whole process did illuminate a different funding mechanism that they're going to use in the short term. And it also brought together folks from that managed care organization and the First Five Commission to think through outcomes and to really think through where there are benefits to the managed care organizations, be it in some of their HEDIS reporting or their healthcare effectiveness scores, versus they have a delegated healthcare model, so whether some of the actual health networks under that organization might be seeing financial benefits. So the feasibility process really helped them sort of map out, again, where they had some data holes that they're going to work on fixing, and then where specific entities within that managed care organization might have some either financial benefits or healthcare reporting benefits for HEDIS. And then another one of our projects was the Virginia feasibility study on home visiting, which Dr. Duggar talked a bit about. And again, data has been a challenge there, as I think you'll hear in all of these places. And so it's taken about a year, but they are just starting to get back some preliminary data linking the home visiting provider data to two of the state agencies so that they can understand some baselines around preterm births, birth spacing, low birth weight, NICU days, and ER days to understand if they might be able to price some of those outcomes and put it in an outcomes-based contract. So again, early stages there, but as that data starts to come in, they are talking with Medicaid and the Department of Health in Virginia to see if there might be an opportunity for them to be the end payer and pay for successful outcomes. And then I'll just touch on two projects that we've been working with for a while that are now in the project construction phase of things, and so that being the actual putting together of contracts. And so one that we're very excited about is with the state of Connecticut, and it's with their MOMS program, which is going to be serving about 2,500 mothers in New Haven, and our hope is that this project will launch in October of 2016, but they're still working out a few of the specifics of the contracting. But this is an intervention where they're using community-centric cognitive behavioral therapy, workforce readiness, and parental support services to help depressed mothers in New Haven. And so the outcome here would be a reduction of depressive symptoms as well as an increased utilization or adherence to mental health services. And so the end payer, it's looking like it would be the Department of Social Services, but they're still working that out exactly. And this would be a pretty big program. The project is targeting to serve about 2,500 low-income mothers in New Haven and have success payments of about $25 million if those outcomes are achieved. And then another project we're working on is with Alameda County in California around asthma control. And so this the County Healthcare Services Agency in Alameda wanted to use PFS to test and scale a combination of two existing interventions, one around asthma management and one around preventative programs in the home, so going in and making some changes to the home. And so they have done a population assessment and intervention assessment. They're working through an evaluation plan. They're going to do a one-year pilot, which will hopefully be launched in the summer or fall to expand these services and collect data on the specific target population. And the hope is that that data will help them secure for a full project a managed care organization to be the end payer. And so there's still quite a bit to work out there, but the pilot they're hoping to launch, and that'll be a pretty small pilot, about a $1 million pilot this summer or fall. And the outcomes they're looking at there are decreased number of hospitalizations and ER visits for pediatric asthma patients. And so I will turn it back to you, Catherine, with that. And thank you again for having me.